And for me, like, especially so young, I felt like my life was flashing before my eyes because they're telling me all this stuff. And, you know, one moment I'm planning for college, and then the next thing is like, if we don't do this, like, she's at risk of like not being here.
Hey guys, welcome back to Nursetalk, the podcast where we talk all things nursing. I'm your host, Mia, and today we have Cailyn.
Hello.
Thank you so much for coming.
Thank you.
Okay, so I always start with why nursing?
So nursing, to me, I pretty much found like that I wanted to do it about junior, senior year of high school. So it's always a career that I've always felt like it was for me. I really liked how nurses in general are just very empathetic people. They're very caring, truly, you know, touching people. And I just felt like that was kind of my calling.
I love that you knew so early on. I didn't know until I was like 25. That's amazing.
Yeah, I definitely like really loved more of like the sciences and everything and math. And that always came easy to me, not really so much like reading and like other things of that nature. So like I always excelled in that in school, and also like in college too. So I kind of felt like that was kind of
The perfect
an
place
easy
to
thing
apply
for me
it.
to learn too. Yeah.
So why oncology specifically?
So back in senior year of high school, kind of midway through, so about November-ish of 2016, I was diagnosed with a rare form of melanoma, unfortunately. I was one of two at the age of 17 that the place that I was being treated at had ever seen.
Wow.
And it took about 2 months for them to even come up with the final diagnosis. It went to 3 different institutions for me to be get a full diagnosis. And with that being said, I didn't have to do necessarily like any chemo or anything, thank goodness. They said if I had waited another month or two, I would have. And my chances of probably being here today would have been like 25%, 30%.
Oh my
so
gosh, yeah.
it was pretty shocking to say the least, because during that time that we found out, that's when you're usually doing like college applications. You're in the midst of all the studying, all the tests, AP exams, everything. So for me, like I felt like my life kind of came to a halt. And so when it comes to oncology nursing, where I was treated, I felt like the nurses that took care of me, like really felt they had a drive to actually help people that get a diagnosis of any sort. And especially for me being so young, they usually didn't take patients as young as I was. I was like the youngest one there.
Wow.
Being 17, I wasn't even technically an adult yet. So they didn't have to, and they did. So I feel very fortunate. And I had multiple surgeries, about 2 or 3.
Wow.
One very extensive one that was about 6 hours long. So
oh my goodness.
yeah, my melanoma was located at the top of my head. And luckily, because I am blonde, I was able to see it when I got out of the shower. My part line was messed up, unfortunately. So when I saw it, I was like, oh, what's that? And then I took a look at it. And then I told my mom, I'm like, this doesn't look good. Like, it doesn't look right. Luckily, I was seeing a dermatologist already. So on my next visit, I kind of addressed it. And they're like, oh, this is not
Good. They
looking
caught it.
good.
Yeah.
And so they're like, we need to take a biopsy. They did. And then so on and so forth. They finally got the diagnosis, then the surgery, and then we were good. It was about actually like because it was on my head and I had to get 6 lymph nodes removed as well just to make sure it didn't spread. It was about like a 2-month recovery, like of being able to like actually move my head, and
Wow.
barely could drive because, you know, no mobility in my head to like looking through mirrors and such. So it was a rough senior year. And with that being said, I kind of missed out on a lot of important things going on. But I had a great support system. I had my family, I had my friends, and that really got me through it. And also my church too. That was good too.
Yeah.
And so that's kind of why I chose oncology. And when I knew I wanted to be a nurse back like before I got diagnosed, I didn't know like specifically honestly what field yet. And then that kind of solidified what I wanted to do with the care and everything provided. So yeah, and that's why I'm an oncology nurse. So,
that's amazing. Yeah. Thank you so much for sharing.
Absolutely.
And I can't tell at all. Your hair is beautiful.
Oh,
you're beautiful.
Thank you. Great plastic surgeons, you know.
So you worked on bone marrow transplant and cellular immunotherapy.
Yes.
Okay, so because that, unit is so specialized, can you kind of walk us through it? Tell us what it's like, what your day-to-day is like?
Absolutely. So I actually, luckily enough, got hired there as a new grad. So I started as a baby nurse on a very intense kind of floor. Yeah. Some would say it's between like a PCU status almost. And, but you're still able to have 3 to 4 patients. So like most of the time your patients are doing okay, but then things can go very south very quick, just with the treatment in itself. So, that's why it's kind of between that like PCU, like, and then they go right to the ICU. And so with bone marrow transplant, cellular immunotherapy, where I work, there is like a sister unit kind of style. So I did more of the cellular immunotherapy side, but we were cross-trained to do bone marrow transplants as well. So my background really is more the cellular immunotherapy. So what we do is called CAR T therapy, and also clinical trials and all that nature. So CAR T stands for chimeric antigen receptor therapy. And so that is pretty much taking a lot of like the blood cancers, so like leukemias, lymphomas, multiple myelomas that we normally would see, and taking the proteins called CD19 protein off of that, or if it's multiple myeloma, it's BCMA, and taking that off and genetically, not genetically modifying it, but like you're taking the protein out and then targeting the specific cancer protein and putting it back into a patient. So pretty much you're taking cells out of the patient and cycle it through, give them back their blood and everything. And what they do is that they take those cells that they took out of the patient and they send it to a specific lab, wherever it is, depending what they are diagnosed with, and the commercial product that they're going to receive. And they take about a couple weeks. They do all that. Then they give it back to us at the institution that we work at. And what they do is they pretty much freeze it. They cryo freeze it, and it's pretty cool. And then what we do is after that, while all that process is happening, the patient comes in, usually starting in the outpatient side of the unit. And what we do is we do lymphodepleting chemotherapy. So we do that to pretty much make their immune system nothing. So we're wiping everything clean. And usually that is involved with like either fludarabine and Cytoxan or cyclophosphamide, or cytarabine, usually the top 3 chemos that we used, depending on what's available. And so we do that, and that is over usually 3 days. And most of the time the patients can handle it. But because we're wiping them so fast out of their immune system, they can start to have the symptoms of chemotherapy. So like nausea, vomiting, diarrhea, all those things. Yeah. And especially them feeling very fatigued, especially. And usually kind of like what we tell them is like, eat, drink, walk, basic things. Don't overdo yourself. And then as soon as all that is done, we admit them into an inpatient side. So literally right through the other door to the other side. And they, on average, will stay about 3 to 5 days. That's kind of what we tell them. Or if they're on clinical trials and getting something of that nature, that is dependent on the trial. So that could be like a week, 2 weeks, a month. We've seen so many different variations, but on average for CAR T products, there's about 7 of them right now. So whatever the rules are, that is dependent on that. And they're admitted, we get them all hooked up. And usually the day of admission, nothing's really happening. We're just drawing blood, daily weights, blood pressures every 4 hours, the basic stuff. And then we prep them for the next day. And usually midday is when we would give the products, because they like to round on the patient in the morning, make sure they're cleared, make sure the blood work's okay. And then we get ready to get going. Nurses actually give the CAR T products, which is pretty insane. But we do like a lot of REMS certifications and such, because it is such a highly like, it's a very expensive,
toxic, or
because it's very expensive. It's $500,000 to $1 million per bag. that they get.
Oh,
Very
my
expensive.
God.
And
spiking that bag must be like, oh.
and what's crazy is spiking those bags is the hardest thing that you can think of. Like, think of a normal saline bag. It's like 50 times harder than that. Like, you are intensely.
That doesn't sound very good. Can you easily drop it or? Yeah.
And in the bag, funny enough, for being so expensive, it's only this big. It's so tiny. And there's only, on average, like 70 mils or less usually in the bag. It's so tiny. But within it, it's about, for every mil in the bag, it's about 500,000 to a million cells. So you got to think about all those cells that are going back into a patient, and every single one of them are targeted to kill cancer. It's pretty insane.
It's amazing.
It is awesome that we're kind of at this point. But yeah, so it's very intense when you go to do it. And not only is like you're worried about the bag, you have like the cellular team that's been taking care of the bag and that's been thawed and stuff. You're doing like double nurse checks. You're checking with them, making sure that, the patient identifiers are all correct. You're checking with the patient, making sure, hey, is that you? Before they get it.
Yeah.
And also like all the families, like, kind of like recording the moment because it's a very sentimental thing
oh my gosh,
to get that.
Yes.
We pretty much say it's a new birthday because everything that they're getting back, they're becoming a new person almost because they're completely wiped out, kind of like a baby. Like they're starting from scratch again. So we say it's like their cellular birthday, which is cute. So some people actually throw birthday parties.
I love
some
that.
people, they
make the best out of the worst.
And on holidays, like it's nuts. Like they will decorate their rooms, they'll do all these kind of things, like, and celebrate it all at the same time. So yeah, it's like very intense, like giving the product, but we like to tell the patient it's almost like it's an exciting moment for them, but it's almost anticlimactic at the same time because they're like, wait, that's it?
You're just
they're
infusing
like,
this?
They're like,
a normal?
why isn't the bag red? And I'm like, no, it's not like a bone marrow transplant. It's not like red or orange or like any like off color. It's like, that's why they gave you back your blood because they only took the cells, which is pretty insane. Mm-hmm. And funny enough, like a lot of patients will say like after they get the transplant that it smells like garlic.
Gross.
Yeah, it's interesting. And then bone marrow transplant, sometimes it's like sweet corn. Yeah, or like sometimes garlic too, just depending.
Interesting.
And so that's when you walk by a patient's room, like obviously the doors are shut, but in their negative pressure rooms because of their immune systems and such. So when you're walking by, you can tell who's gotten a transplant, who has gotten like cellular immunotherapy, CAR T transplant. It's pretty insane. I have never smelled it, to be funny enough. I don't know. Even with being pregnant twice, like I never smelled it, even with a crazy nose. But
so did you have any restrictions being pregnant?
So the only thing that we actually could not do while being pregnant while working in oncology is hanging chemotherapy. Okay. Pretty much everything else is pretty fair game. So I did, and especially with being pregnant, I was doing maybe 2 or 3 CAR T products a day, like on patients. So if some other nurses were busy, they're like, hey, can you do my infusion like for me?
And
I'm
I'll
like,
do your,
literally. We're like, we'll switch for a second. But and during, so literally when I was pregnant, I maybe did 60, 70 of them, 80 maybe. Like I lost count. Like I was doing so many, but I love doing them. And it's great interacting with the patients because you actually just don't hang it and then leave. Like you literally stay in there for the whole 30, 40-minute transfusion. So we like to, as soon as the infusion is complete, we like to turn like the bag over and flush the bag. Yeah. So when you flush it, we're filling about like 20, 30 milliliters of normal saline. That's the only thing that's compatible with it. And rinsing the bag like super gentle because you can actually like collapse the cells because of how they're being handled. We'll turn it over, reinfuse it back, but it's got to start out super slow because when it goes into a patient, it's like shocking, like almost their system again, even though it is their own cells, which is nuts. But DMSO is the byproduct that's keeping the cells alive and not making them collapse and all that stuff. So some people could be sensitive. So we pre-med the patient before and
of course,
all that jazz. Thing, exactly. Usually with just some Benadryl, Tylenol. Mm-hmm. Sometimes some patients will get dexamethasone, very rarely, just depending on, again, if they're on trial or not. Some things are meant to happen, but yeah.
So do patients ever have like very intense reactions?
Oh yeah. And it's not like so common that they'll have like anaphylaxis or anything like that, but definitely racing heartbeat is a big one. So a lot of times they're on telemonitors during the infusion. So
You're getting call after
oh yeah, they're calling me. And then the nurses outside the room, of course, like if anybody knows that somebody's getting an infusion, they're always watching the monitors. They're watching your patient rooms too, because you're in there, like I said, for so long. So if anything is going down, like luckily, like the crash cart and everything is like right there in case they need anything like emergent. But we do have like rescue medications and everything, of course, like on standby. A lot of times epinephrine, Solumedrol sometimes. Like it just depends on what's going on. But the biggest thing usually is like fast heart rate. Sometimes they'll like itch. Sometimes they'll like feel restless. Sometimes because we give them Benadryl before, sometimes they're restless because of the Benadryl, or sometimes they're sleeping through it. So they work up all this like anticipation and they're just sleeping and they wake up and they're like, wait, we're done? And I said, yeah, we were done like an hour ago, you know?
Yeah.
But yeah, during the infusion, every 15 minutes we're taking blood pressures, all like a full assessment during the whole thing. And then if they're tolerating it, then we speed it up a little bit. And if not, then we shut it off, let them calm down, see if it's like something that will naturally go away, and then increase the rate back up. But it's all gravity fed. It can't go through the pump because the pump will collapse the cells, you know, with the tubing and everything in it. So it's very, very like intense. But like when you do it so many times as a nurse, like after so many practices and really knowing what's going on, it's really not that bad. But you always have to almost go into it, not expecting the worst, but like preparing like what potentially could happen and how you're going to do it and the process of that. Because it's, especially if they're on trial, oh my goodness, you got all this clinical paperwork. And if you deviate, it deviates the trial. So it is a lot of pressure on the nurses. And the doctors are never like doing it. They clear them, but they're not part of the process. Same with like the nurse practitioners, the PAs that are underneath the doctors. Like sometimes if they're new, they'll like kind of come in and watch sometimes just to see how the process works. But like it's really all on us. And so it's kind of cool and it's rewarding when you see the aftermaths and everything. Usually a lot of their symptoms, like I said, really don't happen in the moment, but like after, we're expecting with some CAR T products, like 24 hours post.
Oh, yeah.
Or even sometimes by the end of your shift, like something's going on, you're passing off to the next nurse, because I would be on day shift and I'm like, have fun, you know? Expect this might happen.
You can deal with it. Yeah.
Exactly. And but some may not last like 3-5 days, a week. So like, and some people may not even react at all. Very rare, but like we say 9 times out of 10 you're going to react in some form. Most of the time it's fevers. And these fevers are not like low grade. They're 102, 103 fevers. But we always tell the patient it's never a bad thing to fever, because you know something is going on inside you in a positive way. And it's almost backwards thinking. And that's what we tell them. Like, you know, treat this as a good sign. Yes, like your body is like doing it, you know, and it's in there. And what happens is they get the fevers because those cancer cells that go in, they're actually targeting the cancer and killing it. So what happens is the cancer explodes like internally, right? And what does your body do when it doesn't know what it's doing? It has a fever, right? So until that cycles out of you, you're going to be having these fevers. And sometimes they happen for a day, 2 days, 3 days. And we try and see if they can naturally break it themselves before we start doing like intense Tylenol every 4 hours and cooling blankets and all this. And sometimes you'll walk in and they're rigering. So yeah, we're sometimes even giving the patients Dilaudid because to bring down the rigors and such. Yeah. And then the other side is neurotoxicity. That is a big one as well. And that usually happens way after like the first side effects of like fevers and stuff. So like the ICANS with neurotox. So it's pretty intense too, because we're asking the patients at least once a shift, like, what's your name? What's your birthday?
Oh, goodness,
where are you? And they can get very annoyed with that a lot. Like anybody would, you know where I am, you know my name,
Hello, I've told you like 5 times. No.
Exactly. We're like, write this sentence. And they're like, why do I have to write the same sentence every day? And be like, you will be genuinely surprised in the next 4 or 5 days. Like, say something were to happen. And again, everything is so like wishy-washy depending on what they get, the percentages of which patients will get it. Their handwriting can like literally decline, or they'll put their pen on the paper and they're like, I don't even know what's going on.
Yeah.
They're like, I can't write. And then that is like the start of like the signs that, okay, time to start dexamethasone, like it's time. So usually we're contacting the providers like, hey, we're noticing this. You may want to come take a look at them. And then that's when they're like, yep, start everything.
Thank you. Yeah. Thanks for letting me know.
Exactly. So it's it's a very like intense thing. And especially if you have different patients, like I said, you may have 3 patients, you may have 2, you may have 4, never over 4 ever. We only had 12 beds. So it's a very like specialized area that's going on. And sometimes our sister unit, because they're cross-trained, they might take our patients sometimes. So that's kind of like why, we wouldn't have that many patients to begin with. And also we would only have 3 or 4 nurses on and 2 techs. Like it was a very condensed like spot. So like,
seems like it, yeah.
And like our inpatient and outpatient nurses, thank goodness, like with our unit where I worked, we were the only unit that did that. So one day you can walk in and be like, oh, I'm an inpatient today. Oh, I'm an outpatient today. And all the patients know each other, like know us. I mean, like they know. So when they go from one unit to the next, they're like, oh, I had you last week. Or, oh, hey, I remember you. I met you on my first day. Or, or I had you yesterday. So it makes the patients feel very comfortable too, which is very good in their journey because they're most of the time very scared to start a process like this.
Yeah, of course.
Usually it is like a 3rd or 4th line treatment. So before they're doing like other types of chemos, other types of like clinical trials, like whatever, before insurance can approve such a big thing. But they also found through research that using this as a first line anyway would not be really honestly that beneficial. They would rather have other types of lymphodepleting chemotherapies or other types of treatment before doing this one, because this one will nip it pretty much in the bud. So that's why. So it's a very cool specialized thing, and I loved doing it.
And I can tell.
Awesome.
I can tell that you were absolutely passionate about it, and I love that.
And I did clinical leading as well for it for almost 2 years too. So
what do you mean by clinical leading?
So it's kind of like your charge nurse role, but with the clinical leader, it's a little bit different on day shift. So we actually will not take patients because we're running both the inpatient and the outpatient side, creating the schedules, creating the room assignments.
Got it.
If, like I said, like if, another nurse is doing an infusion here, I'm watching their patients. Or if we have 2 RRTs going on at the same time, I'm in one person's in the other. And that happened very often, unfortunately. And so if we are short a nurse, the clinical leader would have to step in and do those infusions, those chemos, and all that on top of all the other duties too. So it is a very highly intense job, even if you don't have patients. So like there's a lot going on. And then the admissions, the discharges, that's all on us too.
Wow.
So it's a lot of moving parts, but I loved it. And
that's awesome.
Yeah.
So you also worked as an oncology infusion nurse.
I did.
So you want to tell me about that?
Yeah. So even though I loved working where I did, I felt like it was almost kind of time, because of how long I was there, that I wanted to explore other parts of oncology. And I felt that the infusion center, where I was currently working, so I just moved different units, was probably the best thing for me. And I wanted to branch out, try new things, see new things, and not be just so comfortable where I was. So what I did there was many different things. So on average, we would see 120 patients, 130 patients a day, any day of the week.
Wow.
And we opened back up on Saturdays. So Monday through Saturday, you're seeing a lot of people. And every patient that comes in can be seen for many, many different things. So that's kind of what I wanted, was a different variety. And it was different where I came from too, because I went from working with 3 or 4 other nurses to 15, 16 other nurses. So I also wanted to branch out too with that and like work with more people in a bigger environment. And yeah, so on average, we had about 28 bays that we were working out of. So at least 28 patients a time is like in the unit, and some are in the waiting room too, to be seen coming in. So we did a lot of different things. So it came from just basic injections, immunizations. We did blood transfusions, iron transfusions. So we would actually see pregnant patients too, which you wouldn't think that you would in an oncology center. But yeah, we would see that from time to time. A lot of sickle cell patients. So they're there 3-4 days a week getting their treatments and such to keep them out of crisis. We would have people there just for chemotherapy as well, and a lot of breast cancer patients. So we would do a lot of cold caps and such on patients too, so they wouldn't hopefully not lose their hair or anything during treatment. But yeah, it was pretty cool. So patients can be there 10 minutes for an appointment, or they could be there for all day. 6, 7, 8 hours. Yeah, so it's pretty
what a learning
intense
curve to learn all
is.
the different, you know.
And what's crazy is it's like the luck of, the roll of the dice. So you don't know what patient you're going to get, like, because it's just randomly assigned to you. And you have 3 bays that you're working out of the 30. So like you have this one little section that you're working out of, but like I said, you can have a patient there for 8 hours. You can have one for 30 minutes, 2 minutes, and you're consistently always turning over your room. So you're going, going, going. And I would be working 12-hour shifts. So I start at 7 a.m. and I'm done at 7. And so you're really like nonstop. But I love that kind of environment too. So that's why it was kind of an easy transition too, going from outpatient, inpatient side that was doing 12-hour shifts to this that was a 12-hour shift. So
if you had to pick, which one would you say you liked the best?
I loved the flow of being an infusion nurse, but I loved the knowledge and all the intense like training that I did through like the BMTCI side. I thought that was really cool, very niched. Not a lot of people know about it.
Yeah.
It was only FDA approved like about 5 years ago now. So it's still like up and coming. All the surrounding areas now, other oncology centers, they're finally now getting into it.
I was going to say, because
so we're like a few of like the founding people, and some even actually like clinical trials becoming FDA approved were through like where I worked as well.
That's amazing.
Yeah. And we're top 10 cancer hospital too. So it's very, very intense. You have people traveling from the other side of the world. I had some patients in Australia. I had some patients in Greece, in Puerto Rico too. So like it can be even like in a small area. Some people come from Texas because their treatments over there aren't working, so they'll fly over. Yeah, some people pack up all their things. I've had some patients from like California. They sold everything and they moved here to get the treatment. And yeah, so that is like the part that I really liked of that, and like the intense like patients that like would stay, and their treatment's usually about 30 days on average. So you really grow a connection, and I loved that part. And infusion, yeah, you may see that patient here or there come back, but like you're really only seeing them for a short amount of time. So I think that's kind of like the catch-22 to both professions.
Give and take,
like, give or take, yeah. But honestly, I would do either, like in a heartbeat, like either side. So yeah, it's really cool.
What kind of training and certifications did you need to administer chemotherapy?
So the great thing where I worked is when you start out as a new grad, usually, or a new hire or anything, they really like for you to get their certifications in-house, which is very nice. So I got my chemotherapy certification for sure. That was definitely one of the first 2 things that I did, because working where I worked in either infusion or the BMTCI side, you're doing that pretty much 24/7. So they always check you off on that. So that's usually about a 2-day course in person, 6 or 8 hours each day. So you're intensely like learning about different types of chemotherapy. You may not know them all because there's so many, but they pretty much touch on like the most basic ones used for our patients where we worked, and also the hanging of the chemotherapy. Usually to get signed off, it would require a person that has been like a super person that we would
super
call
user,
yeah, like a super user and such. So we would have them watch us hang it, administer it, all that stuff at least 2 or 3 times to be able to be actually signed off, which is nice. And that was pretty much like the BMTCI side, and also like the REMS training to be able to administer the types of CAR T products, the trial products, everything like that, because you need to know the signs and symptoms. You need to know like how to treat it, what to do in an emergent situation, all that jazz. So that's kind of what I did over there. The infusion side honestly had way more trainings and like certifications and stuff to get done, because you're seeing more, you're doing more, all that jazz. So what we did is you had to make sure that you were signed off on injections, make sure like check people's blood sugars, like all that jazz too. So doing that, and then also like the cold caps that I was talking about, like we have to learn how to properly secure it on, how long it needs to run for, the pre-cooling and the post-cooling, and all that when giving the chemotherapies too, and the timings and such that goes with that. That's intense as well. And I'm trying to think how to pretty much give immunizations, shots, like I said, all that. So yeah, it's honestly depending on the situation, and if anything new that comes out too, they're always like, you need to get in this class, you need to learn this product, you need to be able to be signed off on all this stuff. So if you're not like seeing it all the time, then it might be like return later, and we'll pull you in like if we see it again. Blood transfusions too, you know, being signed off on that. How to give iron, emergent medications, you got to know all those. So that's kind of like the certifications and everything that we would kind of do in a nutshell. I mean, you can have an ONS certification or an outside like chemo certification, and they will be more than happy to take it, but they still want you, no matter what, to go through all of their standards at this institution too. So yeah, making sure that all the nurses are on the same page, because say you have a nurse that's hired from an outside hospital in, they may do things that are different at that specific hospital than this one. So they kind of want all the nurses and the nurse practitioners, PAs, doctors, all on the same page when it comes to patient care. So of course, it's very nice. So I like that. And it made me honestly feel super secure, especially starting as a new grad. Never really got to touch a patient before because I went to school during COVID. So
same. Yeah. It was terrifying. Right when you get on the floor, like for the first couple months, it's like you're like shaking. Like you don't, you're not used to like touching people. And
they're like, oh, you need to go put an IV in that patient. I'm like, what? I'm like, all I did was remove 50 of them during nursing school and never stuck anybody because they didn't let us. So yeah, little things like that. So it felt really good and nice to know that they actually really care about getting those certifications and all that for nurses to be able to treat all the patients how they should be treated. So I like that.
Yeah. How long did it take you before you weren't so nervous anymore, like to get comfortable?
Okay. So depending on what it kind of is, right? Giving your basic medications, that's easy. Where I was with injections, for example, we could only give sub-Q injections when I was working on the inpatient side, because a lot of patients were on blood thinners. They had no platelets at all. So it was very minimal things that we did. They never got IM injections, all that. When I went to the infusion side, even though I had been a nurse for 3 years, I'm like, I really don't give IM injections. And I'm like, this is going to hurt somebody. Like, I'm feeling so bad. And then that's when I like started getting into it, and even like administering chemotherapy, like by injections and stuff. We never really did that. So like I said, that's kind of why I wanted to like move over to another side. So maybe doing like the BMTCI stuff about like, I want to say maybe 6 to 8 months in, I felt like pretty okay, like pretty comfortable. I wasn't asking like so many questions as much and like bothering people, but other nurses and stuff. So that's pretty much when I was like super comfortable to make like RRT calls and all that. Like I got comfortable maybe like a year in, I would say. I was avoiding them for a while and then like, hey, come help me.
Yeah.
But after that was easy. In the infusion side, I was comfortable because of all the experience I had before. But like learning like the little niche things, I'm like, okay, I might need somebody to help me with this for like really quick. But that didn't take very long, maybe a couple months. But yeah, I think with the more experience and the more time that you have, I think everything kind of plays out faster.
So give yourself a year.
Give yourself a year. At least. Give yourself grace too. And because we were always, like I said, learning so much all the time. And then just when you think you have learned everything, they're like, yep, this is new. We're going to do an intense training for the next month on this product. I'm like, oh, okay, one more thing to my plate, you know? But other than that, there's always a bunch of knowledge that you will open up as a nurse, I feel. So
of course.
For sure.
I mean, who wants to do the exact same thing every single day?
Exactly. And that's, I feel like, why some people become nurses too, because your day is never the same, right? So, yeah.
So what skills would you say are absolutely important as an oncology nurse that many people don't talk about?
You know, I think like a lot of doctors and a lot of nurse practitioners, PAs will walk into a patient's room and they'll be like, oh, you're fine. Everything looks fine. Your numbers are fine. But I think the best skill, it may not even be hands-on, it's really listening to your patient. Because at the end of the day, the patient knows themselves better than anybody. You know, I may know a patient for an hour, 12 hours, doesn't matter. If they do not feel right, that's when I'm speaking up and advocating. And I think advocating for your patient is like the number one skill that you need to learn. I've had patients say there's internally you can see them like almost freaking out through their eyes. And they either A, don't want to say anything because they're almost in denial, or two, they're like, I need help. And that's when like I don't even care. Like I will call an RT. I will take the full thing of it. If my patient says I am not okay, and most of the time they are not okay. And then that's probably like one of the biggest skills I think as a nurse that you need to know is really truly listening and not being afraid to listen to them and even go to bat for your patient because you're there for them at the end of the day. You know,
Absolutely.
Who cares?
Yeah.
You know?
No, I've been called by like the director because we were in Black status and mine was oncology med surge.
Okay.
So whatever wasn't oncology was filled with med surge. So when their, ER is in Black status, of course they're trying to fill those beds. And I had a discharge orders on a patient who literally had an active UTI and had leukemia.
Oh,
and they weren't going to treat her because she tested positive for the UTI at a different facility.
What?
And they weren't going to give her anything.
What?
So I said, absolutely not. Pulled the brakes on. Was like, hell no. Am I sending this patient home? And like one of the directors called me and was like, you do what we say. We said to discharge. And I said, no. You can call a doctor to give her a prescription for a freaking antibiotic and I'll send her home. And I hung up and she called my manager and it was a whole thing.
Oh,
I was like, I don't care. And I didn't get in trouble. They're like, you did the right thing. I was like, thank you.
Yeah, absolutely. And you know what? And what's great is like always having like a manager, no matter what, like go to bat for you is like a great thing too. And especially like in any patient population, especially oncology that you're dealing with, like the low immune systems and such, like it is not a joke. Like I've had...
You can die from a UTI.
Absolutely. Yeah. And I, for example, one time I had a patient say, oh, they're discharging me today. And they were ecstatic, they were excited, whatever. Oh, they signed off, or, oh, the doctor says that I'm going home. And I'm like, you can't get up out of bed. Like, you can't even turn to the side of the bed. I need to like have two people lift you up. I'm like, there is no,
who are you going home with?
I'm like, yeah, who are you going home with? And and then they just kind of look at me like that. And I step out of the room and I'm talking to the nurse practitioners and the PAs and I'm like, you can't be serious on sending this person home. I'm like, they're going to fall the second they literally get into the car, like after we wheel them out. I'm like, no way. Absolutely no way. And most of the time, and we will see it, is that some symptoms start to pop back up again during their treatment. And we're like, that's why you're not going home. Mm-hmm. And that plays into why you can't get up, why you can't sit up, like all these things. So yeah. And
yeah, I feel like I've done that plenty of times. Like, no. You mean you mean discharging to rehab or
maybe
something else? Yeah, so they can, physical therapy or whatever it is, depending on what they have.
Or like the doctors will come in and be like, the patient needs to get up out of bed today. And I'm like, they're laying there like totally out of it. Like, and it's like,
maybe we'll try again tomorrow.
Reevaluate patient tomorrow.
It's crazy.
Or during the shifts. Yeah. It's
you're right.
Intense.
Advocating is.
Yeah. I think advocating is like the number one thing. You can learn any skill in nursing. Okay. You can learn anything in a textbook. You can learn all that. But like having that connection with the patient and listening to a patient, you can't teach that. Like you really have to be on top of it. Because I'm sure
we both have like a million stories that sound the exact same that we went through.
Oh, absolutely.
Yeah, I'm like, no.
Sure.
No. I hear you and I'm going to fix it. Yeah.
And I feel like not even just in oncology, just in nursing in general.
Oh, absolutely. Yeah. No.
For sure.
As a cancer survivor yourself, what advice would you give to a patient who was just recently diagnosed and they're going to start their treatment soon? Like, what kind of things could you say to make them
feel better?
Yeah.
So, and I'll preface, because I didn't do chemotherapy or anything like that, I know the journey is a little bit different, but I've been down that road with recovery during multiple surgeries and everything. It's intense, like, not gonna lie. Like, it is a very hard point in your life, and it's okay to put everything in your life at a stop and to focus on this and to have the support system, to have all the things in your life, like little things, like whether that's a heating bag or, nausea medication, like anything, aromatherapy, that was a big one that we would always use too, to make your life better. We've seen it all the time. Patients will come in, they get told their diagnosis, and they immediately have to start treatment. They never even get the time to even think or process anything. And it's okay. Like, a lot of the services that we offered was a lot of social work, of course, and a lot of chaplaincy too, to come and really sit and talk with the patients, and even nursing, like to sit and talk to them, explain everything that we're doing with them, because they're being told all this in a doctor's office and they're not hearing anything. And I felt that too. Like,
oh yeah.
And
it just sounds like maybe like ringing.
It really is. Like
you like zone out and you're like, oh my God.
Yeah. And for me, like, especially so young, I felt like my life was flashing before my eyes because they're telling me all this stuff. And, one moment I'm planning for college, and then the next thing is like, if we don't do this, like, she's at risk of like not being here in like a few months. Like if we're not doing anything. So for any cancer patient, doesn't matter what you're diagnosed with, right? It's, it's okay to put everything on a pause. Like focus on yourself. And that's not being selfish. Like that is, how are you supposed to be there for other people if you can't be there for yourself, So I've seen it with, unfortunately, a lot of young moms, young dads, even middle-aged people too, and even people that are older that first get diagnosed, and they're always worried about everything that's going on, and rightfully so, because we're human, right? But I'm like, you have to put yourself first in your life for this, get through your treatment for the next 6 months, year, whatever it is, so you can be there for everybody else later. You can be there for your kids to walk across graduation stage, when they get married, when they have kids of their own, and you could be a grandparent, like all these different life moments. So I would say, like, have that in your mind when you do that, and strive for whatever you want after that. Make something a goal to get to. Try and have a positive attitude. It sucks, but doing the basics, walking, eating, drinking, it seems like not stupid, but like it, something so basic that you'd be very surprised with the turnaround time. I've seen patients turn around. They were told you won't get better in another month. They turn around 5 days later, completely better. And you can see it. You can physically see it. A lot of people like in their faith too. So like if you're a very faith-based person, and I am too, like praying a lot, doing whatever, talking to somebody and verbally expressing like how you feel too. And I think
so important. Yeah.
it is very important. And I really feel like that's how I got through it as fast as I did. And trying to have a clear mindset too, not be so Debbie Downer.
Yeah.
And that can be so easy to go down. But I tried saying like, okay, if I complete this surgery, move on, recover. And if I need another one, okay, so be it. Same thing with patients with chemo. They have to go through 14, 15 rounds of chemo. And they're like, this is my 5th session. This is my 7th. This is my 15th. And then a lot of times to make the patients feel super accomplished, we will give them a, where we worked, they would ring the bell.
Yeah.
That they were done. And they're like, even though I'm not like 100% done, it's really nice to be acknowledged that this is one part of my chapter I can close in this, and moving on to the next thing. And they smile, they cry, like happy tears and such. And we give them like a little certificate saying you've completed, and sign all the nurses. And and they leave and they're super thankful, and they praise us up and down, like, thank you so much. And they're like the most humbling patients ever. Like, that's why I love oncology too. The patients are just so, so sweet. And they really, truly appreciate at the end of the day, like you being there for them. So I would say as a nurse, be there for them, because this is the worst down part of their life. And as a patient, I would say just try and be as positive as possible, have the support system. And that's kind of what I would give a little advice to. I know it's hard, you know, but that was kind of in my shoes, what I would say.
I love that. So what is a patient interaction that really stuck with you?
So one of them was like on the inpatient side when I did work there. And like I said, we grow a big connection with these patients because they're there for long periods of time. We're there for them from the start to the end of their treatment. And unfortunately, this one patient was there for at least a month and a half inpatient. It was a very long time. So maybe 2 months long of treatment in itself. But this patient had a previous cancer at a younger age, and she actually wasn't even from this country. She was from Ireland. So way outside the United States.
Yeah.
She was actually a pediatric nurse herself, which is touching to treat another nurse too. And she had another rare form of cancer pop up in her middle ages and such. And she, unfortunately, the treatment didn't work. And she, over the course, was trying other new immunotherapies and such while she was inpatient with us. And she unfortunately didn't make it. But kind of towards like her last like moments and such, we were actually able to fly her family out from Ireland to the United States to be there with her. And while she was waiting for her family and such, she was, we made sure as nurses to have her FaceTime her family all the time. And I loved working with her. She always requested that I work with her. And I was only a nurse for probably a year and a half. So like, I felt like, wow, someone actually wants me to be their nurse here at that point. And, I always made sure that, her hair was washed every day. And, the basics were taken care of for her, of course, and making sure that her favorite show, she had to watch her favorite show every day. And her and her sister were both watching it kind of simultaneously. Aww. And she's like, oh, I'm kind of falling behind. My sister's a little ahead. I'm like, we're putting it on, we're putting the show on. And, of course I couldn't be in her room like all day watching it, but like, I would make sure I would like pop my head in like, hey, how's it going? How's the episode? You got to keep me updated, And, like the reason why we couldn't fly her home either, she was on too much oxygen for the plane to handle. Yeah. And also like for a long journey itself, her lungs would just fill up more with fluid if, so unfortunately that's what kind of the situation played out as. But kind of like in her last final moments, like after her family came and everything, I was not there when she passed. I was there the shift before. So like I saw her almost like at time, and she thanked me so much for being her nurse, and her family wrote me a card. I think it was a week or two after they passed. So they had come home, they shipped the letter here and delivered it to my unit, and it had actually just really my name on it. It didn't have like, our floor in general. So it felt really not necessarily like I needed the acknowledgement or anything, because I will do that for any patient any day, but like the fact that their family knew who I was, she talked about me, she loved the care that I gave, like it touched me so much. And then you don't ever want to like intrude on other like people's lives either, especially like confidentiality stuff, nursing and stuff. But I was able to like write a card back and then send it back saying it was a pleasure taking care of her. And, she was the best patient, like honestly, that I ever had. And she was so awesome. And her sister was a nurse too. So
wow,
it felt really cool to be a part of their life unfortunately in her last moments. But I felt like, and she was all by herself too. Like she didn't, like I said, like have the family be able to come over here. Like she had to pack up pretty much everything and move here to be able to get the treatment.
That's so unfortunate.
Yeah. And it was, I'm pretty sure if I remember, it was like a special clinical trial. So it was the only one that we offered it, like even in the United States where I was. So it was,
like a one last shot kind of thing.
One last shot. And that's how a lot of these patients are, unfortunately. They're like one last shots, and it's either going to be A-okay in the end or the other side of it. So it's sometimes hard, especially growing connections
because
like
when they cancer patients often like come in for a little bit, go home, come in for another treatment, go home. So you see them for a very long period of time.
Yes, that would be like the main difference, I would say, like where I worked inpatient, every patient that came through, you made a connection with them. Didn't matter like if you saw them one time or whatever, because they remembered your face and they remembered any part of the process that you were in. And like I said, so humble, and they're so like fortunate for the opportunity to be able to either qualify for treatments, and two, like either live close to be able to receive it or have the funds to even be able to move their lives here to get it. So it's not like, they do not treat it like a joke. They treat all the nurses with uttermost respect, and same with their family too. And they know like the family can leave for a day or two or go take care of their other needs that they need to with their other families, and they know that they're in good hands. So yeah, for sure.
Well, thank you for sharing that.
Yeah, absolutely.
So what would you say is like the most challenging aspect of being an oncology nurse?
I would say sometimes it's not necessarily like the skills or anything like that. It's more of like the emotional side. For me personally, I even sometimes like, because I was a patient before and now like I'm a nurse, like in their shoes too. It sometimes can be a little bit difficult because sometimes I run across people with my same diagnosis actually.
Yeah.
Maybe not necessarily like the same type, but like melanoma in general. And a lot of times now, since even when I had my cancer, now there's so many different immunotherapies and clinical trials and treatments that a lot of these patients are being put on, and some now are being FDA approved. So I love seeing like that being happening, but it almost reminds me sometimes of like what I went through. And I know my situation was different, but you still get like a little reminder of that point in my life, and I try and be positive too when it comes to that, and say, you know what, like you're here, you're helping other people go through that. And sometimes, like not every patient of course, but like if some patients are like really down in the dumps, like I will share sometimes my story with them,
of course,
and little snippets, not like the full shebang or anything, but I will say like, there can be another side to this, like there can be some positivity. And when I share that, and I can see like the switch in attitude, they're like, oh my gosh, thank you for sharing that. Like, you don't know like how much I've needed like to hear something like that or another side to something. And I don't have anybody in my life that's ever gone through this or like anything.
Well, it must be nice to see like, okay, she's gone through it, but look at her now. She's healthy, glowing, happy.
Yeah.
And she's an oncology nurse.
Yeah.
You know, so you really did turn it around, and it's a great example.
And I tell them, I'm like, you know, literally, like, I was in the same hospital being treated. You know, I worked where I was treated, which is nuts. But you know, I feel like that's like all the timing that needed to play out. And I felt like it was truly my calling to be here. I applied everywhere to be a nurse, you know, where I wanted to specialize. And I immediately got an interview. And after my interview, that was 30 minutes long, they're like, do you want to work here? I said, oh, okay.
Did you share a little bit of your story in the interview?
I did like a little bit. Like I didn't go like through the whole thing, but like I told them like that's kind of like the main reason why I chose oncology.
I'm sure they love that because I mean, are you kidding? Like that's amazing. Yeah.
And like when it comes to oncology in general, they're not just looking for a nurse to work in oncology. No. Like they're looking for people that like truly care and they're compassionate and they can, you know, they literally ask you in your interview, like, can you handle like if a patient were to die? Like, can you handle like any side of the coin, like whether it's a happy moment or a really sad moment, and can you walk through those moments with the patient? Can you do postmortem care? Like, would you be able to do that? And like, and not to make it seem like, you know, morbid or anything, but they really want you mentally prepared for that. Because anybody can do, like I said, any skills, but can you handle that aspect of nursing? It's a very niched part.
It really is. I remember because it was med-surg, it was so busy on the floor. But what the most challenging aspect for me was kind of what you're saying is I would be so busy. I mean, midline is bleeding down someone's arm. Yeah. I'm waiting for stat team to come. You know, one guy needs to be cleaned up in an isolation room and there's no techs available and I can't get in there.
Yeah.
And, you know, there's someone directly, you know, wanting to share how deeply like sorrow they are and they're, you know, stage 4 and they know that they're dying and they know that they only have 2 weeks to live. Well, and they're telling you this while your phone is ringing and you know that there's someone screaming down the hallway and you have so many things to deal with and you had to like balance like trying to organize again critical moments while someone is sharing some of the most painful, deep feelings like
in their life.
And you're just trying to balance all these things. And that was probably the hardest part for me was being present while also being like, okay.
Unfortunately, I need to step away for just a moment.
The second I get out of this room, I need to go address X, Y, and Z. Like emergent things. Like, you know. And
if it's like a 5 or 10 minute conversation, okay, I'll hang, you know, like we can hang for that. But like when it turns into like a 30-minute, 40-minute thing and you're in the middle of med pass, oh my goodness. Like
it's just so
you're like,
hard.
I don't want to be rude. You know, because you want to like hear them out. And a lot of times, like, they don't have family there.
No, they don't. They're all by themselves and like
it's sad.
The person.
And it's not like sad because like, oh, no one wants to show up for them. But like other people that are their support system, you know, they have full-time jobs. They have like kids at home and other things like that they need to take care of before they come and visit you. And also like where I work too, if you were under the age of 13, you couldn't be on the unit. So a lot of these, you know, young patients that have 2-year-olds, 6-month-olds, 5-year-olds, like they can't see their kids for before treatment and after because we're depleting their immune system all throughout. So until
so sad,
it's sad. And like, thank goodness for technology. We can FaceTime and like other things. So I would say that's like a perk, I guess, like to nowadays, like with the technology we have, but it is still very sad. And sometimes, honestly, if I'm looking at the time and say it's like 2:00 and really nothing's going on, but like a patient light's going off, I'll just call my charge nurse if I'm working on the floor, CL, and be like, hey, can you go like see what so-and-so wants? Like I'm wrapping up in here, but like I'm listening and getting them through what they need to be doing. But if it's like in the middle of med pass, I'm like, unfortunately, I'm like, sorry, like I will return back, I promise. And we can sit for however long you want me to sit for.
And I always felt even awkward saying that. Like I would have to like, I would have to like word it in a way. I would get on their level. Like I would get like almost on the floor, like eye level. And I'd be like, and I would let them say a little bit. And then I would like, my phone would ring for the 4th time. And I'm like, okay,
I'd be like, unfortunately, I'm sorry, I have to take this call outside your room. I'll be right back. Like,
like,
that's kind of like sometimes you just have to like,
you have to.
yeah. And most of the time, like, they never will be offended. It's just you feel like
it feels horrible.
You feel horrible because you care, you know, and like you want to like listen to what they have to say.
Thank you so much for sharing this. It's
Absolutely.
just there's like literally an emergency outside the room. I have to, and like all the nurses are drowning, so it's not like someone else is addressing my issue. I have to go out there and do it.
The worst.
It was horrible.
Yeah, like literally the worst is when, because you know, like I said, it's a very small unit. It's 12 beds, right? Like on the inpatient side. And if an emergency is going on, like literally next door, they can hear everything that's going on. And when you have like the next, you know, when you have that patient and the patient that's going on, obviously you're in there for a while. And then by the time you like go to check on your next patient, you'd be like, hey, can we do anything for you? Are you okay? Hanging in there? They're like, is so-and-so okay next door? And I'm like, okay, well, we can't like obviously talk about that. But like, we're like, yeah, like everything's, you know, smoothing over. We're okay. And then they're like, oh my gosh, I hope that they're okay. Like, and you see like
they
the
probably
other
know each other, you know, and talk, you know.
Well, and keep in mind, all the patients there know all the signs and symptoms that can potentially happen, right?
Yeah.
Because they're all told that and the consent form signed and all that jazz when they start the treatment. So they know, oh, so-and-so's in trouble next door. Like
And that sucks because like it probably raises their
like,
anxiety for the
they're like, can that happen to me? And then sometimes like, unfortunately, some of the equipment goes missing in the room and you need it. And you're going through the other patient's story and you're ripping it off the wall and then you leave because it's an emergent situation going on. And
they're looking at you like, oh my God.
Yeah, they're like a deer in headlights. They're like, what is going on? And then we go back in there later and I'm like, we're so sorry that we had to do that. You know, so-and-so needed something next door. Everything's good now. But like you kind of have to like, you know, be
try
careful.
Not to raise the emotional
and
tension
things for sure. And also like you can't talk about obviously what's going on. That's confidential. The next door. So yeah.
The balance.
It is definitely a balance for sure.
What advice would you give to a nurse who is considering being an oncology nurse?
I would say that if you feel like the drive and the passion for it, absolutely go for it. Mm-hmm. I think it is a very humbling thing being an oncology nurse.
Absolutely.
It really makes you look at life differently. Mm-hmm. I think being an oncology nurse too. And like I said, not just even from a patient perspective, but if I even had to just look at it from a nursing perspective, like how much someone can be given with such little time left in their life and what they do with it and what you want your patient to do with it too. We've advocated so many times to be like, send this patient home.
Yeah.
They do not need to be here any longer. Send them on hospice. Do this. And even like patient advocacy, like fighting for that for them. Mm-hmm. And most of the time we can do that. And then sometimes like things decline too fast. But I would say that for someone that wants to be an oncology nurse, like do it. Like don't second guess it. You can always try it. And if you can't handle the emotional side of it, then okay, at least you tried. But they definitely need more patient and more nurses out there that really want the drive to help people like that at their lowest points of their life.
It's a very, very hard floor to be on. It takes a special kind of person.
It is, for sure.
If you could change one thing about oncology nursing, what would it be?
So I don't know if other institutions do this, but like where I work, we have this thing called a code lavender. And a code lavender pretty much means after a patient has passed away, or not necessarily that, or their treatment was just so heavy on the nurses, like physically and emotionally to like take care of them. They offer those kind of services, like chaplaincy comes in and everything. I feel like we should have more of that. And more frequent too. So like, yeah, we had it or have it like where I work, but I feel like once every like 6 months, it kind of happens. I'm not saying it needs to be like every week, but like, I feel maybe like once a month or something. Like they come in and they offer those services like more routinely, to provide like that. And like, especially for like the taxing it is like emotionally and physically on a patient, or actually emotionally and taxing like for nursing, like, and it can be a lot. And I feel like once you have that, like I've felt so much better, like to be able to talk about it, or like at least it being acknowledged that, you know, your feelings are valid. Like it's okay that you felt that way about a patient. Like you're sad for them, and you're happy that you're able to like help them and do everything that you could for them. And yeah, at least like have that be offered for anything. And it may not even just be oncology nursing, just nursing in general. Like if,
absolutely. Yeah.
I know like ERs go through a lot, ICU goes through a lot. So offering like those kind of like code lavender scenarios.
So what do you think that could look like? Do you think that maybe they could round like a couple times a week, or?
So I think like offering it both on day shift and night shift would be good, or at least like near like the start of a shift change or something, whatever is easier for people to, you know, be around for that. I know for us, like where I worked, we would have it in a specific room, and they would provide like literally refreshments. Like they would provide like everything to make it a really positive environment. And because chaplaincy is involved obviously with the patients too, so they know their story as well, so they know and see like how the nurses are interacting with the patients and everything. So to be able to have an open floor and an open discussion and like talk about it and like have your feelings like expressed, I feel like that would be super beneficial for oncology nursing, and I think nursing in general. I think that would be good. Yeah.
So you've probably collected a lot of memories being an oncology nurse. Would you like to share any stories?
Oh my goodness, yes. There's this one time. So when I first started as a new grad, they offered, as a backstory, they say when you sign up, do you want to be on the hurricane team?
Uh-oh.
And I'm like, at the time I was newly engaged, I'm saving to get married and stuff. So I'm like, you know, there's a lot of incentives and a lot of pay or whatever to offer.
Sure.
Yeah, for sure. And I'm like, let me sign up for that. And so I signed up. My first hurricane, I was in the hospital for 5 days.
Oh,
never
my
left.
God.
And I was a new grad. So at first I'm like, oh my gosh, what is happening? Like, yeah, like I kind of signed up for this. I knew what I was kind of getting into, but like not to this extent, you know? And this was a couple years ago. Yeah, about 3 years ago now. And so I had to get an air mattress, blew it up, and then we were like in this big conference room, like all the nurses and stuff. Thank goodness, like our unit had not that many nurses, so we weren't like all jam packed in there. We were all kind of spread out, but like I was sharing an air mattress with one of my coworkers, and I sometimes toss and turn in my sleep, and I fell off the air mattress, and the air mattress is like super high up, like because it was like really thick, and I clunked and I hit the floor so loud that and then my other friend that was on the other side of the air mattress flew up because of like like the change of weight. And then my other friend that was sleeping on the other new air mattress was like, because she was like right there, she's like, are you okay? And honestly, because we were so tired and so like from working so long, I'm like, I don't know. And then I don't know, am I? I don't know, am I? And then I'm laying there and I'm like, do I just sleep here like on the floor, or do I get back up and like hope to not do that again? But it's so funny because I've done the hurricane team like 4 times after that. So like I stayed doing it, and even though it's kind of not fun in the moment, I was like, you know what? It's okay. I'd rather be here with air conditioning than be home with no air conditioning at this point, right?
Absolutely,
And so, yeah, and every year, or like every time that we have like the hurricane, we have to do it. People are like, make sure you don't fall off your air mattress. Or like, you know, remember that time Cailyn fell off the air mattress? And then my boss was sleeping on the other side of the wall when that happened. She's like, what was that big bang? And like in the middle of the night, it was like 2 in the morning. And I'm like, yeah, I fell off the air mattress. She's like, no, you didn't. And I said, yes, I did. And so I would say that's probably like one of like the funniest moments that unfortunately happened to myself, but it's still like talked about.
Yeah.
Like, yeah, it was hilarious. So
dang, 5 days, you must have made buku money.
Oh yeah. Oh yeah, my paycheck was nice. Like I was like, maybe falling off the air mattress is okay in that moment. But yeah, so during that time, during like the hurricane pay, that was also like 2022. So we were still getting COVID relief pay. We got the hurricane pay, and you got time and a half the whole time from when you start and stopped the hurricane. And I had worked 2 or 3 shifts before that. So my paycheck was really sweet. And
Babe, I have the whole wedding paid for now.
literally, I was like, I'm sorry, but not sorry, but like I have to be at work. Like,
yeah,
it will definitely pay off. And it did. And we paid our whole wedding ourselves. So
that's amazing.
Making that kind of money during that, I was like doing everything that I could. Yeah. So it was awesome. And that's why I kind of stayed doing it, because at least those after that, those hurricane, it was 2 or 3 days. Like,
you're
okay,
like, if I can do 5 days, I can do 2.
Yeah, exactly. That's exactly what I did. But now being like on the outpatient side, I don't have to worry about that. I'm not on the team or anything like that anymore. But
that's nice.
It was nice doing that for the last 3 years inpatient. So it was cool.
So looking ahead, what kind of nursing do you plan to focus on?
So I definitely right now am taking a pause in nursing. I just had my second son. So
congratulations.
Thank you. And I plan around like 8 months to a year. Like, so probably coming up in a little bit, I'm deciding whether or not I want to go back to nursing right now in infusion. I definitely see that as like a potential future plan, but I don't know if I want to stay like at home more with my sons or keep going. So I'm definitely obviously going to keep my license. So
yes,
that part will always be with me. And whenever I decide I can go back. But for like certifications, I'm actually going to start a new certification. Funny enough, it's actually not in oncology that I'm going to do it. It's going to be actually more women's health than anything.
Yeah.
So I will be starting that in September. I got accepted actually a few weeks ago. So I'm really excited to start that. And it's going to take about 9 months to a year to complete.
Wow. What is the certification?
So it's through Marquette University, and it's like natural family planning. I don't know if you've ever heard of that, but it is teaching the Marquette method of NFP. And so focusing on like women's fertility for people that like husbands and wives and such, or partners that want to get pregnant, avoid pregnancy, anything like that, or focusing just strictly like finding even fertility in general in women, and without having to use like any forms of like birth control, because I know a lot of women struggle with PCOS, endometriosis. They don't want to be on any of that. So that's kind of like the little part that I'm going to take, but I would love to do that like on the side and go back to like infusion nursing, like PRN or something. So, and also like raise my boys at the same time. So do like a little bit of everything, and it'll be really, really cool.
That is awesome. Do you feel like you became interested in that after, 2 pregnancies and seeing?
I think so. And it's so crazy like how much your body's changed, like even between pregnancies, or even like before when you're trying to get pregnant or anything like that. So it's really cool to see. And I feel like it's like women's health in general is not talked about enough.
Oh my God. No.
That's a whole nother rabbit hole.
We can have like a whole other podcast episode about that.
But it's and I feel like a lot of women nowadays too are trying to stray away from birth control and like the bar, IUDs, like all that kind of stuff. So it's this opens so many doors and so many avenues for people, and it's also like used in other like religious practices too, like for natural family planning. So it's kind of cool that it can be combined all in one. And I'm really excited to kind of go down that rabbit hole and open the doors itself. And I currently use that method too. So it would be really cool to apply that to other couples and such, and teach them, or teach just women in general. So it would be really, really cool. Yeah. I'm excited.
You should make like a whole like TikTok channel and like teach through that once you're like done with it. That'd be really cool.
That would be really, really cool. And what's cool is like you can also like with that work for other institutions that do teach it, and they can teach it all through the United States. Like my current teacher lives in Colorado. So, and we live, here. So on a whole other side of the United States. So it's something you can do, or you can do it locally. You can do it online, freelance it, whatever you want to do. So it's pretty cool.
That's awesome.
Yeah.
I can't wait to see where that takes you.
Yeah, absolutely.
Okay, so I always like to ask if you could go back in time and give your brand new baby nurse self one piece of advice, what would that be?
Give yourself grace.
Yeah.
Give yourself so much grace. Like, you will learn everything, you will do and see everything, and then some. And just when you think that you have learned everything, you can always learn more. And you have done it. You will keep continuing to do whatever you want to do. And there's no, harm in pausing your career. Because I always thought I wanted to be so gung-ho and work in nursing for 20, 25 years. And I do see myself eventually returning back. But it's okay to take a pause, too, if that is what you want to do. And keep your license. It's never, pay for it every 2 years and you're good.
Keep up with it. Never let it go. You never know where life is going to take you.
Exactly. And there's so many different avenues out there. Take every certification. Like, do whatever you feel like will advance you and learn more and do more and see more.
Yeah. So I feel like you kind of just touched on it, but if someone were to come to you and say, hey, I'm really thinking of becoming a nurse, what would you say?
I would say if it's definitely something that you're driven and passionate for, then definitely do it. I wouldn't do it just for a paycheck. It's definitely a career that can be intense and a lot to learn, a lot to see, emotionally taxing too, potentially. And do it if you love it or you think you'll love it in that moment.
Yeah.
And there's so many different avenues in the career that you can go down to. You can always do outpatient, online nursing, inpatient side. And the more experience that you get, the more different avenues you can go down. So I would say do it if you feel the drive for
Absolutely.
it. Yeah.
Well, thank you so much for coming.
Thank you. I really appreciate it.
Yeah. And thank you so much for sharing your story.
Oh, absolutely. Yeah. Anytime.
All right, guys. Thank you so much for watching. Don't forget to like and subscribe, and we'll see you in the next one. Bye, guys.
Bye.